Hello friends, today we are going to talk about a case of a carcinoma rectosigmoid, minimal invasive surgery management. This is 79-year-old male patient presented in the emergency department with severe pain in abdomen, distension of abdomen, bloating and vomiting in the early morning at around 3 o'clock. There was a history of not passage of stool since last almost 6 days, and there was no history of any operation. He is a known hypertensive, but no other comorbidities. We did a CT scan abdomen for this patient, and which revealed the involved segment of sigmoid colon, and probably extending from 4 to 5 centimeters in length, and there is a asymmetrical circumferential inhomogeneous enhancing mural thickening of sigmoid colon, and maximum thickness is of around 12 mm, and it is approximately 15 centimeter away from the anal verge, and there is a possibility of sigmoid colon malignancy with numeral narrowing causing intestinal obstruction. This CT scan image shows that there is a mural thickening of sigmoid colon with narrowing and causing almost complete obstruction and the proximal dilatation of the colon. This is another image which is showing the length of the obstructed sigmoid colon with proximal dilatation. After starting conservative treatment, as this patient was 79-year-old male patient presented with obstruction with the suspected malignancy of sigmoid colon, we want to know the extent of the disease prior to deciding the line of a treatment. We subjected this patient for whole body PET scan, which revealed the primary adenocarcinoma distal 1/3 of the colon T4 and 1 M0. So we planning the colonoscopy with biopsy followed by self-expanding stenting in this particular patient. The thought process for this particular management is the bridge to the surgery, which avoids emergency surgery, which is associated with higher morbidity, 40 to 50% higher mortality, and it allows patients optimization, that is a medical optimization, correcting the electrolyte imbalance which this patient was having, and allows bowel preparation and self and successful elective surgery. Other advantages being it enables minimal invasive surgery, which increases the rate for the laparoscopic surgery, and primary anastomosis without stoma, that is the most important feature, and improved surgical outcomes after doing bridge to surgery. This by the stenting, that improves the short-term surgical outcome, higher primary anastomotic rate, and lower overall complication rate, and increase the lymph node harvest also, and shorter hospital stay. This was the aim for deciding this particular plan for this particular patient. So this is the colonoscopy of the patient, and we saw the proliferative growth at around 15 centimeters from the anal verge. We took a biopsy, and then we saw only one small opening through which I put a glide wire with Siam guidance, and then I tried to put a stent over that particular glide wire, and after putting a stent, what happened is while deploying the stent get moved in the proximal colon, so I have to put another stent, so stent on stent in this particular patient, and this was the final picture where you can see there is a the startage of drainage after putting the stent, and it took another 6 to 8 hours to completely expand the stent. While optimizing medically, this patient which was having electrolyte imbalance that we are treating, and at the same time we have his bowel got emptied, his distension of abdomen is relieved, and patient was quite comfortable, and we got this particular biopsy report which is suggestive of well differentiated adenocarcinoma of the sigmoid. Now this is the we then subjected this patient to laparoscopic uh, anterior resection. After going inside, we can see this stent, and the colon, the proximal colon is almost a normal diameter. We subjected this patient after 6 days of primary colonic stenting, and primary anastomosis done, end-to-end anastomosis of the colon is done without doing diversion ileostomy for this patient. The final histopathology report was suggestive of well-differentiated adenocarcinoma with tumor infiltrates through the muscularis propria reaching into the pericolonic adipose tissue, and all lymph nodes, around 14 lymph nodes are harvested and all negative for metastasis. And the final staging is T3N0M0 for this patient, and patient is doing absolutely fine.